time is over. And thank you, and it's always pleasure and honor to be with our dear HOS colleagues, seniors, teachers. So this first case, he was around 70-year male. He came with complaints of floaters, and he was examined by one of our colleagues and almost declared as normal. And when we saw that there is a peripheral patch, this paint-like patch in extreme periphery, and we just clicked fundus picture and we tried to see the magnified view, and if all of you can make out, there is an occlusive arthritis going on. And with just a simple good color fundus picture, we could make out that this is nothing but viral retinitis starting in periphery. And you can see with intravenous antiviral and then followed by oral maintenance of dose of oral antivirals. I think the whole retinitis resolved nicely. There was a history of herpetic encephalitis 6 months back. So just with a very good quality fundus picture, we could make out that this is a viral retinitis. Now another lady, she had a history of carcinoma breast 10 years back, very well treated, in remission. She came with sudden drop in vision, vitreous hemorrhage, some infiltration and hazy media like this. And we said, okay, fine, we'll start some steroids because there was cells in vitreous and there was vitritis. And we started doing workup for primary metastasis anywhere else in the body. And this is how you can see again imaging helping us see that there is some subretinal deposits, choroidal elevation, and what they call as lumpy bumpy choroid. You can see this speed breaker like appearance in choroid. But most striking for her was when we went for ICG. Now indocyanine green angiography is beautiful when you have to rule out metastasis, because most metastasis will be jet black, and it makes our differentiation from melanoma and other primary ocular tumors very simple. So this is again a very useful use of ICG, and we have had now series of patients where we had a doubt. We went for ICG, jet black lesion. It tells us that this is nothing but metastasis. And finally, it was confirmed that she is having a recurrence and metastasis. Now, another patient having some floaters and not much change in vision. You can see 6/6 vision in both eyes. But when we went for angiography, we could make out in nasal quadrant there was some stippled hyperfluorescence and this leopard skin-like appearance on FFA. But we still, and at that point we did OCT also over that nasal area, and you can see that there is some splitting between Brooks membrane and RP happening. But we still thought that because viral retinitis is something which can progress very fast, so our first DD was still viral retinitis. We advised antiviral. He didn't turn up. He came back after 6 weeks. Now vision has dropped, and same thing is now involving macula. But now I think picture is quite clear, and you can see this RP getting separated from Brooks membrane and subretinal deposit, and lot of vitreous cells, and they are very well defined, reasonably large cells. So of course we still said let's give him a trial of antiviral and steroids and see whether he will improve, but he didn't. And when we finally went for diagnostic vitrectomy, it came out to be primary intraocular lymphoma. And when we go back in literature and see the OCT findings which we were observing at macula was very classical of primary intraocular lymphoma, and he responded very well for intravitreal methotrexate. This patient, again, he was having some mild uveitis. All the serological investigations were normal. He was having occasional flare-ups which was very well controlled by topical and rarely with oral steroids. And then when we took a very detailed history, he had some history of mouth ulcers and genital ulcers. He came out to be HLA-B51 positive. But you do angiogram for these patients, the picture is much more striking than what color picture shows you. There is a diffuse leak around all the vessels, cystoid macular edema. So he fits very well into Behçet-related retinal vasculitis, which keeps coming and going like this. So again, now he's maintained at 6/6 with 8 years follow-up. So again, imaging helped us. Another lady who came with headache and this kind of sudden blurring in both eyes, some disc edema, and when you see a picture like this, you will always wonder whether it is posterior scleritis or is it VKH or is it APMPP. And angiography is showing hot disk leakage at optic nerve head and pinpoint leaks also at multiple points. But the moment you do ICG, I think ICG again is a very striking, has a very striking imaging appearance of this disease called VKH. What you see is uniformly distributed these black areas. This is nothing but hyposenescence because of inflammation of choroidal stroma, which is quite uniform and diffuse, and it's strikingly bilateral. Sometimes disease looks very asymmetrical, but on ICG it is quite symmetrical. So diagnosis was very clear once, and we gave her steroids followed by immunosuppressives, again maintained very well. Now sometimes you go for fundus and FFA and you forget your basic OCT scans. Now look at this patient, young lady, which he came with sudden drop in vision, and what you can see here is this boat-shaped subhyaloid hemorrhage, and there is a ruptured retinal artery macroaneurysm which has led to this. Some hard exudates on this fundus picture, and angiography is showing relatively normal looking fovea and macula. But let's see what's happening at the fovea on OCT. There is significant traction there at fovea along with all these findings which I have highlighted. So this was not a candidate for laser or injection. This was a candidate for surgery. We operated, and you can see this. He recovered quite a good 6/6 vision. So it was only because of B-scan OCT we could make out that it is the traction which needs to be addressed rather than just retinal artery macroaneurysm. Again, this PDR patient, just to highlight that sometimes you see when he presented, he was having 6/6 vision, subhyaloid hemorrhage, and after follow-up, hemorrhage actually gets absorbed, but vision drops. And why it's dropping? Because there is a traction which is developing at fovea. So again, B-scan is very important test for even when you you see macula which looks like very clear, not much of hard exudates or macular edema. Sometimes you can see traction in these kind of cases also. I think this one again was a patient complaining of sudden blurring when he was on traveling on a bike, and he came with this kind of lesion, choroidal lesion, and we thought whether it is tuberculoma or choroiditis. But when we did angiogram, we realized you can see the serial angiograms showing diffuse leak over the lesion, and you do OCT scan over this lesion, you can see this choroidal elevation, lot of inflammatory cells, full thickness retinal opacification, but no necrosis. So this tells you that it's not viral retinitis, it's probably a choroidal granuloma, and he responded very nicely to just oral steroids, and you can see this lesion regressing nicely. Again a choroidal granuloma, and I think this was a patient where we were suspecting a CNVM which was not detected on FFA ICG, but OCT angiography showed it very well. So to conclude, I think multimodal retinal imaging can make huge impact in variety of clinical situations which we see in our clinic, and I would re-emphasize that it is still underutilized. Many of us have these imaging tools, but we are using it less than what we should. Thank you.
Thank you so much, Dr. Deependra, for a very interesting case.